So I'm Kellie Hurley. I'm the stroke coordinator at VM, and I was just listening. I've done stroke for a long time, and even every time I hear Fatima talk, it like triggers my brain to different things. And so I think, like, how do we operationalize all those new evidence-based practices? And I feel like the stroke things are always changing. So it's like last month they asked me to do this, now this month I've just been different, and it's like, oh my goodness, things are changing so quickly that keeping up with the new literature, because it is such a dramatic outcome for our patients, the differences that we have made over the last 6 months, that it's just, we have to try to keep up the best we can. So I think as someone who helps change in hospital practices, I feel for everyone that's involved, because this is constantly changing. So I'm just curious, what audience do we have? So I'm guessing nursing, any physicians, anyone else I'm missing? PCTs or techs? Speech therapy, perfect. Huge, important piece of it. I think we'll talk a little about that. I'm just going to briefly go over some, how do we operationalize all these things Fatima's talking about. And I was just thinking as she was talking, I think it's really important to take away the extended window. So in January was the big reveal that we were expecting starting last fall, that we've gone to the 24-hour window for all stroke patients. So that's really exciting. And I don't know if you guys have seen this here. I'm trying to think of a couple. We get quite a few patients from you guys. You guys do an excellent job getting these people fast treatment. And so the biggest group of patients this really changes everything for are wake-up strokes. So previously, EMS, if you woke up with stroke symptoms with unknown, last known well, or greater than 6 hours presumed, right, if you're sleeping, is that we didn't work you up for stroke. And we're like, oh, well, sorry, there's nothing we can do. But did you have the stroke 2 hours ago, 30 minutes ago? Was it 8 hours ago? And so now these people are getting evaluated, and that's so important. So we've seen some really dramatic outcomes, and I'm not sure if Dr. Robinson's going to share that case or not, but people literally coming with the NIH at 26, take the clot out, and they're totally normal. It's crazy. And so that's really exciting, and that's the difference that we can make. And even though you're an hour and a half away from Seattle, you guys can make a huge difference, because there is a possibilities for these patients, and we've seen it. All the times add up, and we're going to talk a little bit about that. But you, over here, but everyone plays a huge role, and it takes everyone's participation in this, everyone from the CT tech until the lab to pharmacy, right? It's a huge amount of people that have to make this happen, and so that's why we work so hard at this. And then I think as humans, we love time goals, right? So someone tells us this has happened in this amount of time, we have a reference to watch, right? And so we're always trying to bump those times to be shorter, and we can always do better. And so even though we think we're doing it quickly, there's always ways to shave time. And so Cody and I will always try to figure out how we can get more time off the clock. And you guys have done a fantastic job. So I think in the last 3 months, literally all code strokes have had CT-CTA at the same time. And now that's becoming just kind of normal. And that has been an adjustment, I know, but it really makes a big difference, because someone has a large vessel occlusion, alerting all the right people as soon as possible makes that treatment really quick. And so that's super, super important. All right, so those are my thoughts from Fatima. And so just really quickly, we have seen a lot of changes in the last 6 months, and so we're going to continue to see more changes. I think there's some more studies coming out this fall about TPA, maybe looking at a larger window for TPA. There's a lot of things that are changing because of our advanced technologies. Using rapid software, which we'll talk about more later, has really changed how we look at stroke. And then data. So data is everything now. I don't know if you've noticed, all these fields in Cerner, and Cody will go through this, but when you go to county meetings, and Cody and I go to a lot of those, it's all about data. So how can we take this data that we have to help drive stroke care, trauma care, STEMI care? And so a lot of it falls back to the bedside staff to put in this data. So it's a huge amount of requirements on the behalf of the nurse, and so just know that is all being used for really good use later. It's just not always really visible up front. So that's really, really important. And then being inclusive of all patients. So patients, we need to look at our window a little bigger of what patients are we looking at for stroke, because they can come in all sorts of varieties, different presentations. And so how can we as practitioners at the bedside really make that decision as quick as possible? And the interfacility transport, that's the next thing I think our state really needs to focus on, is how do we get people between hospitals as quickly as possible? And I have to say your fire department here does an amazing job, where they have I track all of the times from your guys' door out to our door in, and it's always 67 minutes or 72 minutes. It's super fast. So they do a really, really great job. So how do we pick which tool we use? There's a million stroke scales and stroke assessment tools out there, and they all have their benefits, but no one's like really sold on any one of them, right? Because they all good, but none of them are like, oh yes, that's a stroke, right? And so it really depends on us as practitioners to utilize these screening tools, but also use our critical thinking cap to then kind of run through your differential in your head of what is going on with this patient, and keeping stroke high on your differential until you've proven them otherwise. So this is kind of looks at the different scales that are out there and the circles on the different parts of the brain that it assesses. So like the FAST is mostly your middle cerebral artery distribution or your classic stroke symptoms, but we're missing your posterior circulation with that exam, that screening tool. So how do you decide which tool to use, right? So really what's gaining traction is BEFAST, because 1 in 5 patients are having a posterior circulation stroke. That's a lot of patients, right? And we're missing these people because they often don't fall into the category of FAST. And so most hospitals in the Seattle area, paper about 2 years ago out of Stanford, Kaiser's gone with it, is looking at BEFAST as our way to triage for patients for stroke. And I think you guys have started to go to BEFAST recently. It's an adjustment. Everyone experiencing that adjustment? It's a thing, because B and E are challenging. They're not as classic as your dense hemiparesis with your speech changes. Right, so FAST is face, so facial droop, sudden onset. A is for arm, and S is for speech. And so adding B and E is balance and eyesight. And this is going to target your posterior circulation strokes. But who works in the ED here? Yes. So you're like, oh my gosh, well, how people come in with balance issues? I don't feel well, the room is spinning, I'm dizzy, I've been nauseous, right? That's a really common thing people come in the ED with, and it's really challenging for our EMS crews as well. Well, one way to think about it is those sudden onset, right? And of course, that could be vertigo, it could be Meniere's disease, there's other things that could be causing that, but you should definitely rule out stroke on these patients before you, as well as the other things that you're doing as well, because those are the classic signs of posterior circulation stroke. So an example of that would be, so for balance, we had a patient that was at a hotel. He had just flown across the country for a conference, woke up at 5 in the morning, and had to go to the bathroom and stood up, did not feel well, and just like literally ran straight into the wall. Like that's how bad his balance was. Sudden onset, unexpected, wasn't drinking the night before. Like this is a weird onset for him. And sure enough, he had a huge clot sitting in his basilar artery. And so those are the patients that you're looking at, is that sudden onset. Your spatial awareness is weird. It's very similar to vertigo, but it's usually more severe. And then eyesight, the two big things with eyesight are sudden onset. So again, that's really key with this, sudden onset of blurry vision and visual field cut. So you can just do a little exam looking at their peripheral vision. It's usually the easiest, but it's something they'll complain of, and it's usually, again, sudden onset. So think of that as your differential, look at your comorbidities, and rule these people out for stroke. Any questions on BEFAST? Takes a little while to get used to. So you guys know, vague symptoms in the ED, people are not good historians, right? Which medication are you on? Do you have any past medical history? No, I don't. Oh, I take warfarin. I mean, you know how they are. So it's like, it's really up to us to identify this, because nothing will happen unless one of us or EMS starts the process of thinking stroke. And then headache, nausea, vomiting, again, that happens for everyone, it seems like. So, but just again, keep your thinking cap on about that. So, also, I think it's interesting, literature supports that 90% of code strokes will not be real. And that makes me feel better as a practitioner at the bedside or helping a team do this, is that most of the time it won't be actually real, and that's okay, and that's what's expected. Only about 10% of patients we work out for stroke will actually have a stroke. That's true for EMS, ED, and then inpatient code strokes as well. So feel good about running them through the scanner and getting rid of that off your differential, and that way you know you're keeping your patient safe, because we do not want to miss this, because stroke is very, very disabling for these patients. So BEFAST positive, less than 24 hours, think stroke, and like Dr. Milford was saying, is that with our posterior circulation, we actually go further out for thrombectomy, so just always keep that in mind. So minimizing delay between transports. So this is a big deal, is how can we, as facilities that work together, how can we get people that need to come to Seattle there as quickly as possible? And so there's no set goal for this right now. There's recommendations we'll talk about, but how can we make sure patients get quickly to Seattle if they need to as quickly as possible, to a comprehensive stroke center. So think of all the time that goes by. They're in their house, they probably called you after maybe feeling this way a couple of hours, right? People like to say, I'm gonna lay down for a little bit, I'm gonna call my mom, or something else is going on. It wasn't that bad. My hand just felt a little bit weak for a while, and then now my leg is weak, right? People always wait to kind of see if it'll get better. So you've wasted time there. EMS arrives. They have a very quick scene time, usually less than 10 minutes for these patients. Get to you guys work them up, run them through the scanner, call VM, get a rig, get to Seattle. This all takes a ton of time. So what can we do as a team to help shave this time? And I just always like to show visually all the people involved with the code stroke. It's a lot of people, right? And a lot of communication has to happen, and people do a really, really, really great job at this, making this a priority. So like Fatima kind of brought up, the pearls of times, and some of these are published and some of them are kind of the standard of care we're trying to develop, is door to CT less than 25 minutes. That's CT and CTA. Even for hemorrhages, you want to get a CTA. TPA less than 45 minutes really is going to be the new goal. So 60 is current, but 45 is recommended for most cases, and so that's really, I think, will eventually be the new standard of care. Door in, door out of your facility is 120 minutes for all patients, so 2 hours. 90 minutes is probably going to be what the recommended goal is eventually. So I like to say 50% of the time we should get patients out of the ED within 90 minutes, if not faster. And then once they get to a comprehensive stroke center, they need to have a groin puncture within 20 minutes. So really just in the door, fly downstairs, and prepped on the table, and a groin puncture. So does it seem realistic to you guys, or what do you guys think about these times? It seems doable, right? With the right, if everything goes as it should, right? This seems realistic, but this is what's tough. But I think if we have goals, we look at the clock, start the timer, we can totally make this happen. Just everyone kind of has to be involved. So quick identification of stroke symptoms. We'll keep repeating it because EMS, I think, doesn't get all the credit they deserve for how awesome they do. Think about that. You walk into someone's house, there's like all sorts of things happening. They're not well, they're probably having a stroke, so they might be able to talk. Maybe someone's around to help you get a history on them, and quickly saying, oh, this is stroke, let's go, right? That's a huge piece of it, is quick identification. And those that walk in, I mean, I don't know about you, but we get the funniest walk-in strokes. I'm like, why didn't you call somebody? You know, they're like dragging their leg and someone's help clearing. I'm like, oh my gosh, like people do the funniest stuff. And so that's just on us in the ED too, is like, how can we quickly identify? I don't know if you have funny stories, but there's just so many silly things that happen. People don't want to bother people or whatever it is, but you know, it's just amazing. And drilling down each step is really important. I mean, it's crazy how, like, if you really drill down each step, who's putting the order in for CT, who's taking them to CT, who's helping them get them off the table to CT, who's putting in the IV. Like, there's all these things that have to happen, and how can we as a team work best to make that happen? So it's something every hospital is always working on, and I think it's fun to collaborate with all different hospitals. I'm always talking to other facilities in Seattle too, of like, well, because everyone's trying their best to make this as quick as possible. So these are all the kind of the goals that have to happen for a patient that needs a higher level of care. Is door time here, so the stuff that Cody and I look at every month. How quickly are we accepting in Seattle if we need to transfer this patient? So your team's calling VM if they need to get out of there for acute stroke, and they're quickly accepted. So how we make that process really quickly. Letting EMS, they do need transport, and then getting them to Seattle, and then groin puncture with our IR team. So it's looking at every single step. It's complex. So just so you guys know, at VM we do have an acute stroke line. This is mostly important for ED physicians, but I think it's good for all team members to know kind of the whole process. I think it's really helpful. So there's a separate line for our transfer center because stroke is obviously a huge emergency, and so this is answered by a nurse immediately, and then you're connected with the IR and neuro hospitalist, neurovascular trained physician. Usually within 10 minutes. Our goal is less than 20, but we usually get it between 5 and 10 minutes. And then Dr. Milford showed you the stroke algorithm. This is just based off the AHA guidelines, and what do we do for patients in the 6-hour window? It's a little different than the 24-hour window, and so how do we break those people up? So that's available, and Cody has copies of that as well. Any questions on acute stroke treatment? Getting things fast. Anyone have any feedback or suggestions?
Will they still give a thrombectomy even after they've got TPA?
Exactly, yep. So you give TPA and then down for thrombectomy as soon as possible. Yep, so the TPA will help, and sometimes people do have quite a miraculous recovery after TPA. I don't know if anyone's seen that. Like, it's pretty dramatic sometimes. It's pretty cool. But often the clot, if it's a large clot, it'll need also to be removed by a mechanical thrombectomy. Yep, it's pretty exciting, and Dr. Robinson will share a lot of those stories with you.
That's a good question, because you're worried about
bleeding
in the blood.
Yeah.
Poke around. Is there a higher risk of bleeding? that's been one good thing that's come out of the trials. Even the early trials where we weren't selecting the right patients, they were kind of neutral. There was actually no increased risk of bleeding after doing a procedure after someone got TPA. So it's about the same risk as just giving TPA and having bleeding on its own. So it's a pretty safe procedure even after TPA. Well, I think one of the things is TPA half-life is pretty short. So, and if you think about it, TPA is great, especially for small clots. That's why it's still so important to give it really fast for anyone who qualifies, because it starts working right away. But it's just that that chemical process can't break down the really big clots in time. So those big ones are the ones that we need to get and take out mechanically.
Yeah.
That's a very good point. And in addition, now the guidelines from this year, the updated guideline, they have patients receiving TPA and going for thrombectomy. That's standard of care. So that's really important.
Yeah. Yeah.
Okay. Kind of along those lines, if
Sure.
Are we sending patients with TPA running?
Great question.
And
Yeah.
if we are, does EMS have, like, I mean, how familiar are they with?
Yeah, it's a great question. So for your guys' fire department here, they do transport TPA. In Seattle, the paramedics do not do it there. So it's a nurse car. So it depends on your county that you're in of how they decide that. But yes, so the drip will be started here. It'll finish in transport, whether it's airlift or EMS.
And that's actually a question that the state's working on right
Mm-hmm.
now. There's that whole inter-facility transfer guideline work group.
We have a lot of work to do on that group, yeah.
Yeah, there's a lot. That's a question everyone's still asking. Not entirely sure how to answer yet, but our crew does pretty good.
Yeah. The biggest piece, I think, too, with Roby saying about hemorrhage after TPA or thrombectomy is that it really comes down to blood pressure management is really, really important. So making sure that after thrombectomy, there's very specific blood pressure parameters. When you give TPA, having it less than 180 after it starts, and that is essential for our transport crews to know as well, because you want them getting flow to the brain, right? Because your blood pressure is really high when you're having a stroke. If you notice a classic stroke come in, the blood pressure is 220 over 140, like that's really common because the heart is trying so hard to squeeze flow past that clot, right? And so you're gonna have a naturally high, really high blood pressure. And so getting it safely lowered, you don't wanna lower it too low, right? Because you want that flow going, but with TPA to keep it safe to decrease their risk of hemorrhage, which would be devastating if they had a hemorrhage after TPA, is that it really comes down to blood pressure management, keeping it less than 180 with labetalol or nicardipine. And so EMS crews do carry that. So yeah, there's a lot of steps, right? Yeah, so it's interesting what county are we in, Cody, here? Kittitas? Yeah, that makes sense, right? And so, but King County, they do not transport. So funny, so. Yeah.
One more thing.
Yeah.
You briefly mentioned.
Yeah.
I know the answer, but can you talk about doing the CTA even if they have a hemorrhage?
Yeah. It's so funny how, like, you see the CT, you got to see this big bleed, right? You're like, oh, that's it, I got it, we can move on. Now I know this patient's got a huge hemorrhage and we got to go down that pathway. So it's really important about hemorrhages, and Roby, you can mention this or go into more detail on this, is that what is the source of the hemorrhage, right? Why did this happen? Because that really lets their team know what do I need to prepare to do for this patient when they get here. So that the aneurysm, we got to secure that aneurysm. It's a special team to do that. If they've had a large hemorrhage that has some sort of other vascular abnormality, it's really important to know those things as soon as possible so they can know how to help the patient. I don't know if you want to expand on that at all either.
That's a big part of kind of the talk coming up next.
Okay.
We can go into that more the next hour, but yeah, it certainly, it gets to that whole idea of etiology, what caused this, and it's always information we want to have. And now that we're seeing that we can do the CTA so quickly and so safely, that just adds more to the care to know what the cause of the hemorrhage is. And it's a scan that we're going to get anyway, so to do it right away is helpful.
Yeah. Awesome. Well, I will hand over to Dr. Ryan, Roby Ryan.